Okay, so we don't have folks from DMH. I'm sorry. This is, welcome back, Health Corrections and Institutions. It is Thursday, May 15th. And we are shifting to mental health services for folks who are incarcerated and under DOC. We have Dr. Richards, who is from WellPath, who is the Regional Director of Psychiatry. Welcome. And then Mental Health Director within DOC, Colleen Nielsen. So welcome, folks. And again, if both of you, before you speak, could identify yourself, but if you could just give us some overview of the population that you are working with within DOC, issues that you're seeing, how you're working with Department of Mental Health, how the contract with WellPath is being carried out. General overview. So I'll leave it up to you two to determine who goes first.
Yeah, thanks for having us here today. I did share with Isaac, and I think Isaac shared with you a training that I did for the courts recently, yes, that has a lot of just basic mental health and actually co-occurring services within corrections, because we really try to do co-occurring services anytime we work with anyone.
So we got new people to the world here. Could you explain what co-occurring is?
Sure, it's looking at both substance use issues as well as mental health issues within this population. And so we don't
often they're intertwined.
Right, they're married, they're together. We don't separate them. We don't have a bifurcated system. We really have to look at both issues. And so that document sort of walks through from the moment they step into our doors to the moment they release, what is some basic information around services they deliver at each individual step. And so I was asked to do that by the judiciary, and so we put together this training, which I've shared with you, rather than duplicating a presentation. So I don't know if people had an opportunity to review that, and if there are questions about that, or if I should just walk through it verbally.
Please.
If that would be easier.
I think walk through it verbally quickly. We haven't had a chance to look at it, but it might be also helpful to know how many folks WellPath and you folks are working with within our facilities who are suffering from issues of mental health. And there is mental health, but there's also the SFI population and the distinction between the two. And what you're really dealing with, what you're
Sure.
working with.
Does it make
And
sense?
we also have DMH. We have Karen Barber. She's on Zoom. I'm saying from DMH, and we have Nicole from DMH here as well. And Isaac is up to something.
Probably trying to access the PowerPoint or get me a copy of the PowerPoint so I can walk through it.
I'm gonna give Isaac.
Mary, can you grab that from Gina?
No,
PowerPoint.
Present.
PowerPoint presentation. I beg your pardon.
So much. Free to jump in. So co-occurring mental health and substance abuse treatment is outlined in NCCHC standards, which we're NCCHC accredited, which is a national organization on health standards, as well as statute, BSA 28907 and 801B. We provide mental health and substance abuse services, urgent and emergent, on-call and on-site, 24 hours a day, 7 days a week, 365 days a year. All of our mental health professionals are considered QMHPs, as designated by the commissioner in the Department of Mental Health. So they're all trained to do the same evals that like a court screener or somebody in the court would do. We don't need to call Howard Center, for example, or, the designated agencies to do those screenings. Our staff are trained to do those screenings in-house.
Let me stop you right there. So qualified mental health professionals are within WellPath.
Correct.
They're not separate DOC employees.
Correct.
They are under WellPath, and this is part of our contract, healthcare and mental health care contract with WellPAC.
Correct.
So that's important for the members to know.
That's, the QMHPs are like an emergency, they can do emergency examinations. If someone is in need of that level of care to be involuntarily hospitalized or make referrals for voluntary hospitalization. So they're trained to be able to submit the paperwork to the Department of Mental Health.
So so is this done at? Let's take it step by step.
Sure.
So when a person's coming in, they're going through booking. You have one of the qualified mental health professionals there at booking to do screening.
Yes, they usually see them very quickly, if not within hours to
Within 3 hours.
3 hours usually.
One per site, roughly how many people are we talking about?
Our mental health team, gosh, the number, I would say we have around 20 staff throughout the state. So
This is at the facilities.
correct, with Springfield having the most, because if we get into that, we have some mental health beds down at Springfield, 38 mental health beds.
It really depends on the size of the facility, how many staff. So it's really a staff per inmate number versus, having them equally distributed. But DOC is required to provide all levels of care up to, but not including hospitalization. And that's where the MOU with DMH comes in, that we collaborate with DMH to get people into that level of care as needed. And so having
Which level of care? The level one?
hospital level,
The hospital.
inpatient level of care. And that's why having qualified mental health professionals as designated by DMH is important, because they can help do those emergency evaluations to get people into that higher level of care. And so part of my job is to really coordinate with DMH in getting those folks in the care that they need. We can't provide it.
So say a person's coming in, I'm gonna do this step by step. A person's coming in at booking, they're evaluated. The court did not send them. I don't wanna go down this path, and at least I'm gonna say it, but let's not go down that path. The court did not send them to our state hospital for evaluation. They didn't feel it was necessary. They charged them with they were charged with criminal activity. And the court decided to hold them and not release them back to the community. And during your screening, your mental health person determined this person really does need to be at our state hospital for stabilization and more evaluation. Does that occur at booking at times?
Yes,
So that would be an involuntary placement at
Yes,
the
if-
hospital, state
if they're
hospital.
not willing to go voluntarily, we always follow statute and offer voluntary, but if they're not willing and they need hospitalization, we will proceed with that process.
And that's through the courts.
Correct.
How easy is it to get a hospital level bed these days? I mean, we hear we're in sort of a crisis, with the, reduced beds from 52 to 25 at the state hospital, units closing around the state. So is that tough?
Not really. I mean, we will work really well with the Department of Mental Health. When we file the paperwork, if it's supported, it has to meet a certain standard. But once we file that, usually we have like a little team where we coordinate to get the patient to the hospital. And it's either VPCH, Brattleboro Retreat, or Rutland Regional.
We have 50 beds in the system.
Decentralized system, yeah.
We replaced the state hospital, when we lost it to Irene, had 52 beds. We replaced it with 25 beds at the Berlin Hospital, 14 beds down at the retreat, and 6 to 10 beds at Rutland. So we have about 50 beds. Level 1 acuity. That's important to remember. Level 1 acuity. That's when folks really are in dire straits and need to be stabilized.
For a little background, prior to taking this position with the Department of Corrections and WellPath, I was the medical director at VPCH for almost 10 years. Left in 2022 just to take a break, 10 years.
PCH,
VPCH, the Vermont Psychiatric Care Hospital.
that's the one in Berlin.
And so I had some interaction with the Department of Corrections at that time, doing needs assessments, which is part of when there's a court order, if someone commits a crime, and someone's screened and a judge orders an inpatient evaluation, there's another part of it, which is an evaluation by a psychiatrist to see if they meet the standard and need to be hospitalized. And so I would do those when I was at BPCH, and then had that overlap, and then decided to come work corrections because I would just say there's a great need for it in the Department of Corrections.
Yeah. So say a person has been there for 3 or 4 months, and they start escalating, mental health issues start escalating. And what then happens within your world? They've escalated to the point that they need to be hospitalized.
I would say we always try everything we can within our system. So if we have individuals at different facilities like St. Johnsbury and they're not doing well, one of the first steps we might take is to transfer them to the mental health unit at Springfield first to see if we have a great team at Springfield, more staff, but there's more acuity. So we might try everything that we could, medications. I guess I would say it's a different experience working in corrections after working at hospitals, but we treat it like it's an acute inpatient unit. We can't do medications if someone's refusing unless it's an emergency, which is a new policy, but we will try everything we can. But if somebody's not doing well and they need that level of care, then it's kind of a step-by-step. We'll work with them, try to meet someone where they're at, offer medications, offer therapy groups. We get as creative as we're allowed to with a very controlled environment. And then if not, we'll offer voluntary hospitalization. And then if they need involuntary, we'll do it. The paperwork.
And if they are sent to the psychiatric hospital, how long do they stay there? And what determines when they do come back to the incarcerative setting?
It really varies. It's so individual to each person. We've had people stay hundreds and hundreds of days. We've had people stay weeks. We've done a great job, I would say, with the Department of Mental Health. We care coordinate when someone's ready to return. I know Colleen does, I think, weekly or monthly meetings on the status of our individuals who are in hospitals. And then we will do a team meeting with the social worker, the psychiatrist, our team to kind of determine where, if somebody, ideally, sometimes they don't return to incarceration and they are out in the community in some other supervised setting. But if they do come back to corrections, we will determine where the best place is for them, and then we'll touch base, and we try to make it like a seamless transition.
So testimony we've received in the past is when someone does hit that acuity level where they need to be hospitalized at the psychiatric hospital, they're there until they're really stabilized, and then they'll come back to DOC.
Yeah.
Is that still the practice pretty much?
Yes. Yeah, I would say people are usually stable unless there's some sort of legal hiccup. People are stable when they come back.
And what are you seeing in terms of the mental health population over, I don't know how you both have been working with DOC, but in the time frame that you've been there, what are you seeing as trends or population changes that are coming in? Is DOC picking up, housing more folks with mental health issues? Or is it stabilized over time?
So I started with the Department of Corrections in 2002. So I've been there for 23 years. And I've been in this position for 8 years. So definitely in the 20 years, the population has changed quite significantly. The level of acuity is just, I don't know, like it's shocking.
It is. I would echo that. Having worked at UVM and then the state hospital, it's pretty shocking.
And what are you seeing for acuity when you say level of acuity? And how it's, the level has increased. What, can you give some examples? Just for folks to understand.
Yeah, I think on all levels. So there's the like the amount of substance use. Back in the day, 20 years ago, people would come in with like an alcohol use disorder. And now it's very common for me to see charts, and I did over 1,000 chart reviews last year. So I'm very familiar with the diagnoses that our population has. And it's cocaine use disorder, stimulant use disorder, opioid use disorder, cannabis use disorder, cocaine use disorder, methamphetamine, it's all of those things. And so when we talk about treating opioid use disorder, we have a medication and to treat that, but folks are coming in using, and now I guess whatever the WASP situation is, it's going to be a new disorder. And so just the level of substance use that we're seeing, the level of mental illness, the level of trauma, the level of personality disorders, the level of intellectual disabilities, developmental disabilities, and it's not like, you're working with a person who has a serious mental illness. You're working with a person who has serious mental illness, 5 substance abuse diagnoses, an intellectual disability, autism, and a personality disorder. That's what you're working with. So it's very challenging to sort of create individual programs to meet this very complex individual. And that doesn't even talk about their medical issues, because they're often have diabetes, hypertension, high blood pressure. So they have all of that as well. And so people are just really sick and really not well. And that has shifted in the 20 years that I've been there.
And has it shifted in terms of ages that you're seeing? Are you seeing this more in the younger age group, middle age group, older age group, or does it not make a difference?
Our population often reflects the larger population in that way as far as aging. So our population is definitely aging as well. We're having folks who are just older and older in our population, which does contribute to the complexity of their medical issues or their medical diagnoses.
But what you're seeing coming in, the different population now in terms of substance use and behavioral issues, is that more prevalent in the younger folks that you see coming in, or it's across the board?
It's for the most part across the
Yeah.
board.
And is that contributing to, is it behavioral issues that they acted out in a criminal way, or is it criminal thinking that, or are you just not geared to answer that question?
For the first 15 years of my career, I was a clinical person within risk reduction. So I actually do have some experience in that area. I think it's really hard to pigeonhole. I think that there are people whose criminal behavior seems to be the direct result of their either substance use or their mental illness. And then there are other people who maybe have a mental illness or a serious mental illness, but also have a lot of criminal thinking.
Yep.
And so it's hard to just say, everyone with a serious mental illness is here because of their serious mental illness. And then everyone, who doesn't is just here for criminal. I think it's just, pigeonholing people is, I don't like to do that.
Kevin and then Connor?
I just want to make sure I'm hearing you right. It sounds to me like over the experience you've had, which is vast, the population is growing and the variety is growing within Vermont.
Yeah, the health data that's in this spreadsheet, 96% of our folks are on medication and are on more than 5 prescriptions per patient. So that's a shift for sure. 60% are on psychotropic medications, and that's at least 2 medications per patient. So that's a lot of medication, that's a lot of illness, that's a lot of treatment.
At the risk of stating the obvious, we're doing something wrong.
There's a lot, speaking to the medication piece, our patients tend to have very mostly disjointed care in the community. So they're going to urgent care or they're going to different clinics to get their needs met. and get prescribed, it's kind of like, oh, you're here today, here's your medication for this, and then here's a medication for that. And there's both, I think it's both. It's not either or, it's like both prescribers are just wanting to do something. That's sort of our medical model. You come into an office and I'm going to give you a prescription when you leave. And then patients sometimes want certain prescriptions. And by statute, we have to continue every medication someone has in the community if it's verified. So even if they're on, I met a guy a few weeks ago that was on 8 psychotropic medications and opiate on methadone. And I was like, I went to meet with him personally with a staff, with one of my providers, just to say, like, this kind of polypharmacy is dangerous. We have to continue it and get a release to talk to the provider in the community and kind of figure out what's going on. Because I know that psychiatric services are not easy to come by in Vermont, and especially in the rural parts of the state. So we have a lot of people with a lot of trauma and a lot of different diagnoses, and really what we're trying to focus on is like, what do we really think is going on, and so that we can provide the best kind of care and evidence-based, medications and treatment.
Connor and then Troy.
Thanks so much. Really tough job you have, I think. And it's tough because, we send people to prison, not just to punish them, but hopefully when they're out, they're less of a danger to themselves and others as well there. But by the nature of like mental illness, I would think in a way that could exacerbate. It's such a stressful environment, right? And maybe you could get them on a good medicine pattern and stabilize them that way. But it still feels like you risk them maybe leaving in worse shape than they came in, right? And that's concerning to me. So I was wondering if you could talk maybe just about, for the institutions committee as well as the corrections committee, the physical setting that you work in. I look at other state models, and some of them have like facilities that look more like a hospital and are dedicated, entirely to folks suffering from psychiatric issues. And as we look into the future, should we be looking at something like that? The other, I was hoping, and I'm sure it'll come up, just the transition into the community as you started touching on. How confident are you that when they leave, they're going to stay, sort of on the pattern that you set them forth on? Or could it be very dangerous if they get off those meds that they relied on for a period of time? So that's a lot of questions to throw at you.
I think my experience, and you certainly speak to yours, but I feel like it's varied. Some people really do get stable in facility, and it really is a structured environment. It provides heat, clothing, food. Maybe they were homeless and they didn't have access to medication, and so they do sort of get well in that setting. And it's when they leave that things start to fall apart for them. Other people struggle in our setting because it's in jail. It's not a pleasant setting, so it's very traumatic. It can be triggering, it can be traumatic, it can be overwhelming. I'm thinking of somebody who maybe is not willing to accept medication for like psychosis, and so they're have a lot of psychotic symptoms, and being in a general population unit with 70 people when you're struggling with auditory and visual hallucinations is challenging, right? It's triggering, it's difficult. And so some people do struggle in our setting, and some people actually, it's the only place where they've actually been well. And it's when they get in the community that things fall apart. So that's my answer to that question. But I think you had a lot.
You think the percentage of people, and I know it's varying degrees, we have the unit at Springfield there. You think the percentage of people suffering from psychiatric issues could warrant having a facility in Vermont dedicated that looked more like a hospital than a prison to get people on a better track when they're going out? Because I've been to that Springfield unit, it doesn't look like a hospital, it's
Yeah, thanks for reminding me of all your questions.
I can blab forever.
No, I mean, I think that the facilities are always a struggle. Like I'm thinking of Northwest, for example, just for an example. And I know that's not, you were talking about Springfield specifically, but Northwest is structurally, it has one place that people can meet as a group.
Mhm.
So whether that's visiting, church services, court, substance abuse groups, mental health groups, AA, Turning Point, like everybody has to fit in into that one space. And so it's very hard to deliver a full range of services when you don't have the actual physical space to do that. Springfield's a little different because it's our newest facility, and so there is space, or more space, but it's still a jail, and it still very much looks like a jail. And so we don't have, I think we try to make, gardening and try to sort of provide activities and provide things that sort of mimic the hospital in some ways, but it certainly doesn't look like that. And would people benefit from that? Yeah, absolutely. I think the whole population would benefit from that, not just the folks who are struggling with mental illness. That's my opinion as a mental health clinician. I think living in those environments is just harsh for everyone. It's harsh for staff too, frankly. Going in and spending the first quite a few years doing direct service in a facility. It's just a very depressing, harsh, sad, just really difficult place to work. And I was only there 8 hours a day. I can't imagine what it would be like to live there. And I'm not seriously mentally ill and don't have, multiple substance use issues. So, I'll stop talking.
No, it makes sense. I think I can compare to like the Waterbury State Hospital, like having worked there as a resident until the flood, and the environment of care. I mean, my opinion as a psychiatrist, the environment of care really is important in psychiatry. We call it the milieu. And it's sort of, everyone is sort of, if it's an 8-bed unit or a 75-bed unit, everyone is part of that environment, and it can really impact other people's wellness. So when the state built VPCH, that was night and day almost, the facilities. And then going from VPCH, which I'm kind of like is on this hand, and then corrections, it's just night and day, the environment of care. So it is very challenging to try to mimic and to implement what it would be like to be in a hospital for our patients, if they're, especially depending on the milieu, right? If we have a lot of individuals not wanting to take medications, but they don't need to be at the hospital, and we have to monitor for safety. So letting people out to rec together or not, we really have to, it's just very individualized how much time people get out and when they get out, depending on who's on your unit with you. So yes, a nice new facility would be nice, but that's not up to me to decide. But, we make do, and Southern State does have quite a bit of space, and we are creative with WellPath healthcare staff, with DOC staff. We're very much partnered with being creative with the security team around individuals being able to go to the gym or go, even if they're on the mental health unit, being able to allow them to go to the gym and do other things if it's in their best interest and it's safe. So we're creative. I know you asked another question at the end.
Yeah, and you probably get into it. I might be jumping it, but we talked a lot about the MOUD program and the transition into the community upon release, and how you make sure that do they go out with a prescription? Do they go out with medication for a certain number of days? Like, just what does that transition look like, and how do you work with community partners?
Yeah, it really is individualized, but everyone now gets a 30-day supply of medications in hand when they leave the facility. That's
The MOUD, your other medication, but not the MOUD.
well, they get enough to get them either to their appointment.
Right, the MOUD,
Correct.
right, but not 30 days.
You mean opiate, like?
Right.
Yeah, I don't know if that's, their appointments are usually within 7 to 14 days. So they'll get enough to get them to their appointment, not 30, but not standard 30 days.
Right, but your other medication,
Yes,
not the MOUD, but your regular medication, psychotropic or heart, diabetes, they leave with a 30-day supply.
yes, in hand, which is a newer thing that has happened.
I will say I think the challenge in that area for us has been, and still is, very much our average length of stay for detainees is 3 days. And often when people go to court, we don't know what's going on, so they could just leave and then they don't have their medication. Now, presumably, if they've only been with us for 3 days, they still have, their primary care and their medication and their stuff in the community. But that's an average. And so somebody might be with us and just leave. And we don't know what's happening, to them. So that coordination, and sometimes those people have been very ill. And so I think we have talked a lot about what that means to have somebody who is like, actively psychotic, for example, leaving Southern, leaving an acute mental health unit in the middle of February with no place to go. I mean, that's never, that's like,
It's worse.
Dr. Richards and I take like our own personal time to cry. Like that's a horrible, horrible situation for anyone to go out to. And so I know that defense attorneys are, trying to do their job. But that's horrible. Nobody wants to see that.
Troy?
Thank you. My question has been evolving through this conversation that Connor just started. Dr. Richards, I want to go back. Let me just try and frame this before I'm going to be talking and thinking at the same time. I picked up on sort of the example you used of realizing this person had 5 different psychotropic prescriptions. It seemed like that was surprising to you, and you wanted to meet with this person and find out. And then, we have these statutes where we can adjust that as necessary. My first question is, I'm curious to how well that's working, and is there a statute that's in the way right now of allowing you to make the decision of let's right size this, or however you want to say it, right? We have to make some adjustments here. This doesn't seem right to me. I'm wondering how easy or hard that is for you, given the statutes that are currently in place. And then we've been messing around with H32 precisely about this question of how do we provide continuity of care for detainees that are leaving? And we hear testimony from one person who was recently released. He had been there for, I think, 4 months. So he was below the 6-month threshold that would have allowed him to leave with medication. And I've been struggling with how do we frame that? How do we make sure that as our people are leaving, even if they've been with us for 2 months, 3 months, 4 months, that there's still that continuity of care that I feel we're obligated to provide. And right now, we're not. That obligation doesn't feel to me to be in place. And so many of our incarcerated Vermonters stay with us their entire time as detainees. So I want to make sure we can do whatever we can between now and whenever we're done with H32 to shore up some of these things that are in the way of providing that care. We hear a lot that we don't know when they're going to be released. They could go to court and then suddenly they leave from court. We've also heard from folks who have been incarcerated tell us, well, we know, right? Everybody, right? Most of us have public defenders. They're in consultation with the state's attorneys. We know that we're going to go to court and be released. I'm not saying what you're saying is inaccurate. I'm just saying we're hearing a lot of information and I would just really love to tie that up somehow. So there are a few questions there. I guess the first one is how easy or hard is it for you to make the adjustments you want to make? And then any advice or best practices you might want us to consider, especially around the continuity of care for detainees. Whether it's 3 days or 3 years.
The medication piece, the statute does allow, if it's not medically necessary, that you don't have to continue a medication. So if someone comes in, an example would be if somebody is prescribed high doses, I'll just be honest that a lot of every day what I help manage with my staff is amphetamines and stimulant prescriptions. And there are a lot of risks. I won't go into that, but there's a great New York Times Magazine article like a few weeks ago that really goes into ADHD and stimulants. That's a very good read. But so we have the ability, if somebody has like methamphetamine and cocaine and fentanyl in their system when they come into the system, we don't have to continue it because there could be a medical complication, cardiovascular disease, and risk to the patient. But that being said, I don't know, it's a complicated environment. I would just say, working initially, I'm also a child psychiatrist. That was my first job up in Plattsburgh, and then I went to the state hospital. But as a doctor and a psychiatrist, usually you want to work with people that want help and want to work with you. At the state hospital, it wasn't like that usually because people are involuntarily hospitalized. And then in the incarcerated world, the patients, I just have been shocked at how, I'll just be honest, like at how litigious and how many threats the providers and myself get like day to day, threats of lawsuit or threats, I'm going to sue you or I'll do something to you if you don't write the prescription someone wants. And we try our best to explain, like, if you have trauma, we want to offer you evidence-based treatment. And we're really working on a lot of groups and see cognitive behavior therapy, dialectical behavior therapy, evidence-based treatments that aren't only medications. But the statute, I think it's just tricky. You have to, on the other hand, I could say, I have a son who has epilepsy, and my greatest fear was always if he got incarcerated, I would want his medication to be continued, and to be guaranteed that he wouldn't miss a beat of his medication. So I can see the intention of it. And I think there's leeway. So I just work with, it's hard once people are on medications to, if you're invested in that medication or if you have an addiction. Some people, I will say, do need medications for ADHD. We prescribe what people need. We try to coordinate with the community providers to see if they want to prescribe them. But, I will say more recently, that also sort of puts community providers at risk. And you may have heard in Berlin, is it Berlin, that People's Health and Wellness is no longer prescribing any stimulant medications, period, because of threats to the staff at that clinic. I think it's a free health clinic. So, my take on it is ADHD medication is never a life-threatening emergency. You can miss days. As a child psychiatrist, I always would tell my patients, skip the weekends. Your kids should take the summer off. But it's sort of like we kind of have to, and we deal with a lot of grievances over it. But I don't know that I necessarily have issues with that being your priority to change that.
Yeah, we talk a lot about, so I've been in this role for 8 years. I've gotten 2 grievances about counseling in 8 years. All my grievances are either about stimulants or medication-assisted treatment.
That they didn't receive.
That they're either being taken off for whatever reason, or there's not enough high enough dose, or, something about the medication. We recently started a DBT group at Chittenden, which I was 8 years trying to get that going.
Can you say more about that? I don't know.
Dialect.
Yeah.
Dialectical
CBT,
behavior therapy.
Yeah.
Could you say that again so we could hear it down here?
Sure, dialectical behavior therapy. Yeah, it is a specific therapy that is evidence-based for personality disorders, specifically like borderline personality disorder. It provides coping skills for a lot of emotion, a dysregulation of emotions. And so really helps people in those areas.
Yeah, especially people with trauma, which have a
Trauma,
high
lot of
population
trauma.
of trauma. There's mindfulness, a lot of research into it being effective. And so that was sort of the push to get these groups going. And you were going to say that.
One person completed the group.
So we're trying to offer what we think is, it's multi-pronged, multifaceted, but oftentimes people don't want what it is that we have
It's
to.
true in the community too, right?
True.
Like when we go to the doctor, we don't necessarily want to do some long drawn out thing. We want like a pill. Like we want it to be able to resolve like immediately. We don't want to do PT. We don't want to do, we just want
Want it fixed.
Yeah,
fix,
yeah.
right?
To go
We
away.
all do.
Can I just ask a follow-up? And if we don't get to continuity of care for detainees, that's fine too. That's gonna be an ongoing question anyway. As I think about all these things you're developing, DBT, whatever, how is your staff to patient ratio and what are the caseloads? And are they within what would be considered reasonable ranges? Whether that's group therapy, whether that's individual therapy.
This is probably, you probably have better ideas of exactly how many staff, but I will say that we've been really blessed. Not only to have a lot of like wonderful Vermont people to come on board and work with WellPath and work with us. But we've also been blessed, at least in the mental health and the psychiatric realm, to be staffed, mostly fully staffed. I think we've had some issues at Northern, so in Newport, to find clinicians. But so I will say that. So that's been great. So we're fully staffed and have been since the contract started. And I also just want to say that I know there's been a lot of conversation about WellPath. But as somebody who has experience now, this is the third healthcare contractor. My experience is that it's been so refreshing, not only to have a contractor who is really aligned with our values, and staff who are really aligned with our values, but also to have a contractor who's really committed to making sure that every piece of the contract and the requirements in the contract are fulfilled. Historically, the big part of my job was just arguing with the contractor to say, like, you agreed to do this and you're not doing it. Like, I don't have those issues anymore, which is so refreshing. Just have to point out that how refreshing it is to focus on care and not have to argue with a contractor every day about what they're supposed to be doing. Back to your question about staffing. I think that at this point, what is the staff to incarcerate individual? I mean, some of it depends on acuity, right? So we have 1-2 people at Northwest.
2 people at Northwest.
And how many people are at Northwest? Do you know?
I could pull that number. In a second.
Couple hundred, so maybe like one for every 100 people.
Yeah, it's an
A high
interesting,
caseload.
yeah, it is a high caseload. We work on triaging. I mean, if you think about it, it's this entire system of care that can range from like emergency examinations where people are acutely violent and psychiatrically very like seriously functionally impaired to just, could I get like some coloring pages or could I get like a workbook or a journal? So those kinds of requests, our staff manage all of those. Like I want a journal or we're rushing to a unit to respond to an emergency. So it's I would say it is very difficult work, and I think we're fortunate. We have a really great relationship also with DOC and Colleen, and we're very much aligned in the care that we're providing, educating our staff to.
How would 1 per 100 compare to sort of the nationwide best practice standards?
Not the answer to that question.
And it may not, maybe we can get you those numbers. I'll tell Brianne Castle, the mental health director, I could get a better sense of.
And so does that, I'm sorry to, one more, does that play into what took so long to get a DBT program going? Is that a staffing issue? Is that a philosophy issue? What is that?
It's a philosophy and culture, do you?
Well, it's also a contractor compliance issue. Yeah, I mean, to be honest, it was just like, this is what I want to do. And Brianne and Dr. Richards said, that's a fabulous idea. We'll do it. And so it was just, again, refreshing to be like, been working for 8 years to try to get a group going. And it was so easy with this new contractor to be like, oh, sure. Well, that makes total sense. We'll do it. And it was up and running. Versus like fighting. We don't have the space. We don't have the staff. We need more training. Like it was just something.
Where was that pushback from? Was it from the provider for health and mental health care, or was it more coming from the facility end for the pushback?
The pushback was coming from the healthcare contractor.
And can I say, like, I think, I believe that, and I also think like a system of care, and like if you're talking about a cultural change or philosophical change to the way care is delivered statewide, human behavior is so, people who have been working in their positions for maybe 15, 20 years and they're doing what they do. And I'm not, contractors change, and it's sort of an interesting phenomena to me that people are just kind of like, no, this is how we do stuff. And you have to come in and be like, actually, we're going to be doing it differently, and trying to promote change is a very complicated process. But we've had great luck. Just, we go to the sites, we work with the teams, we kind of explain the importance. And then our staff are pretty willing to take that step. And then they're like, we only have one person. And they did one at another facility, I think, that had one person. It's like, keep going, we're going to keep
doing it.
offering.
Yeah, the superintendents have been really great about figuring out space and trying to get it done, even if it means like we have one office space in one of our facilities where literally if you peel back the curtain, there's a toilet.
Yeah.
And they're meeting with clients in this room.
Yeah.
With the toilet. It's a little awkward, but it's finding space. That's the challenge with the infrastructure that we have, is that we have to, even if it means
Pulling a curtain.
pulling the curtain.
So we have some more questions here. Kevin and then Sean. Not Kevin, Brian. That's right, you looked at me, Kevin. Brian.
We've sort of talked around seriously functionally impaired a bit, and I thought I understood when the chair was talking about it, that it's almost like if somebody has this designation, here's what you do for them. But obviously there's got to be a way of diagnosing that. So what is that?
What is seriously functionally impaired?
Yeah,
Well, it's dictated by statute, right?
I know, I was trying to look at it, but yeah.
So it's very broad who would potentially clinically qualify. But the first thing we do, and this is going to change a little bit, with DMH and Dale, changing how they do their waiver system.
With 1115 waiver?
So DMH has what they call CRT level clients.
CRT, yeah. That's out in the community.
Out in the community. So when people come into booking, we ask them, are you receiving these waivers in the community, whether it be a TBI waiver or a developmental disability waiver or a mental health waiver in the community? And if they are, then they'll automatically be designated seriously functionally impaired, because we know they're receiving the highest level of community services. And so we know that they need to be monitored and closely, right? Like they're already flagged as being a person who has some impairment in the community. The other way we can do it is the clinicians will assess people. And typically people have to have a serious mental illness or developmental disability or traumatic brain injury or dementia or something that seriously impacts their ability to function within the correctional environment. And it's important to note that it's within the correctional environment. So some folks who have maybe an intellectual disability, for example, can actually function pretty well in a very structured environment. In the community, maybe not so much because they're left to their sort of own devices, but in a structured environment like ours, they may not meet the SFI criteria because their functioning in our facility is really good. Some people may meet the criteria because they're not taking medications, and then they start taking their medications again, and then they're functioning better, and they don't meet the criteria anymore. So it can be very fluid. But with the community waivers, it's not fluid. They're designated, they're always designated. We can't remove the designation.
Even if they are functioning.
Even if they are functioning in the community, in the setting.
So there's the two paths. You can diagnose within the facility,
Yes.
but it's also piggybacking on what was happening outside.
Correct.
Yeah.
And then part of my role is to make sure that the folks that come in either come in with a waiver or are designated in the facility my job is to monitor those patients, not only in the facilities, but also at release. And so how are we reconnecting them to either the services that they were getting in the community or before they came in? Or how are we getting the newly identified people re-engaged in the community into CRT or into whatever? I think with the 1115 waiver, one of the great parts of that is that we can try to get them assessed prior to release. And so they don't sort of drop off when they get out. Because if they're not reassessed, then they lose their designation within 90 days of incarceration, after 90 days of incarceration. So we have to get them reassessed when they come back out for like a TBI waiver, for example. And having the provider be able to bill and reassess somebody prior to release versus setting them up for an appointment the day of their release or the week of their release. They're more apt to get lost, right? Because they've got all kinds of things going on. And if they're struggling to make all these appointments, they miss the appointment, they don't get the services, it's sort of willy-nilly whether they show up or not. If we can get them assessed prior to release, then we can try to get those services more seamless. And so when they get out, they already have it and there's no like going to an appointment or doing any of that. It's probably a longer answer than you want.
No, that was great. Thank you. Yeah, definitely.
So Sean?
All right, so I'm in more of a Troy, trying to figure something out here, and so it's a little bit of a step back, and it's not so much talking about the drugs, it's talking about housing after and how we're setting people up for success. And are we? So these people that you're taking care of that are then released to society, do you feel or do you see that they are actually set up for success? Are they going into a nurturing place that's going to take care of them? Are we doing that?
No.
No,
Okay,
that's the short answer.
that's super helpful. Should we as a state be having supportive places for people to go into?
It'd be great to have a step down sort of place.
What would that look like to you?
And under whose jurisdiction?
Well,
It's
the world
is.
Yeah, I mean, it's ironic that you say that because I have a once a month meeting where we go over all the cases that could be released if we had a place who are also designated SFI. And it's
You're talking about people that are under your watch that you can't let out because there's nowhere for them to go, a house, a halfway house, whatever. Thank you.
It is by far the most depressing meeting that I have to attend on a monthly basis.
Mhm.
We have people who are 10 years past min because we can't find a place for them to go. We have people that we've tried to get reconnected in the community, but because of their level of care needs, it's going to cost the last person we tried to partner with our sister agencies to develop a plan for release. It was going to be $750,000 a year to house this person in the community. One person. And so when you look at comparing $750,000 a year to whatever the cost is to have them incarcerated, you can guess where they still reside.
So, right, still hanging in there with me, and I ask you because you're there, you're dealing with this all the time, you see this happens. So I'm not saying I want to have a mental hospital because everyone, that's not what we want. But what could we like shoot for? What can we? It's not going to happen tomorrow. But what would you like to see? What would fix that problem?
I think so what they're getting now is, obviously meals, housing, clothing, heat, electricity, whatever. They're getting counseling, they're getting psychiatric care, they're getting their meds delivered to them. They're getting reminders about getting their meds delivered to them. And and then the step down is, if they're lucky, an apartment by themselves where somebody checks in on them once a week. Like that's a huge jump, right? And so it's not surprising for me when people end up returning quickly. Because going from such a rigid, sort of structured, supportive environment, because jail can be a supportive environment, even though we're not always seen that way. To go to live in an apartment by yourself with somebody checking in on you once a week, it's just not the step down that I would like to see. More of a supported living group home sort of situation where there is somebody to say, not you have to take your medications, but hey, it's time to take your medications, like here's your meds. Like, nobody does that in the community.
We used to have halfway houses here in Montpelier.
Mhm.
Those people used to come to my house for Thanksgiving and Christmas because my parents would go get them. They were really wonderful people, but someone lived there in the house to do just that. Is that something, a model we need to kind of maybe look at again?
We have a little bit of that with Dismas.
Yeah, this much.
That's so few.
So few. And the
Yeah,
question is who pays, who has supervision,
Right.
who has control.
I'm just wondering, like in a
That's the
perfect
question.
world, how would you set that up?
I mean, even just I don't know who would supervise it or like what kind of, sometimes again, like the court thing, like when we have some patients who are SFI, like those are our group of patients that are seriously impaired that don't know when they're releasing. We usually do, but if we don't, and then they don't really want to engage with us, those are the really hard people to be able to say, okay, we're gonna send you here where you could get like some way to communicate. We scratched together a plan not too long ago for an individual with serious epilepsy that, it was like, what are we gonna do? Like there's nothing really. And he was impaired enough that we had to kind of take what he wanted, and there just wasn't anything. I don't know. We did these things together. I think maybe probation parole got him a phone or something, and then we kind of pieced together this plan, but I don't know, some way to kind of funnel people, because he wasn't a candidate for Dismas House. I don't recall any little pathways, because I think he maxed out, he was detaining, and then it just.
I think the challenge is, and this is a challenge for the state, I think, I would love to be in an environment where I'm just working with people who absolutely 100% want to be with me and doing the work with me. Like, that's just not my experience of reality. And so we struggle in the Department of Corrections because we know that in order to have people be stable and safe and not reoffend, we know that there's certain things that they need. But if they don't if they're not 100% bought into all that, then they don't get it. And so where's that line? I mean, I don't know where the line is, right? Where is the line between personal autonomy and public safety? Like, it's a philosophical struggle, frankly. That we deal with almost every day, or I deal with almost every day. Because people don't often want the services that are there, and DMH can only do what they can do for people who want it. So, like, we have people who are like, oh no, I'm not mentally ill, and and we're like, you can barely manage day to day, but they don't identify as being, struggling. So if they want to be homeless on the street, living under a bridge, like, that's good, but they want that. And who am I to say that that's not? I mean, that's not good.
Yeah. Gotcha.
So we're gonna start tying this up because we have to shift gears a little, but Kevin?
Oh, that's all right.
No, go ahead.
I'd be unpacking it further. I was thinking from the questions that Sean was asking, Representative Sweeney was asking, is there a population that are stable enough in your mind to try to transition, but they still need a bridge? And if there were 75 beds where they had the camaraderie and the oversight, but they were free enough to do jobs, maybe in the facility, outside of the facility, get their feet on the ground outside of being incarcerated. Would that have enough benefit to be worth looking into long-term?
I think there are definitely people who could use, I don't know about 75 people, but I definitely think there are people who could use that step down as an option
So it's smaller
and
than
would
that.
take it.
It's
would
smaller than that
agree
in
with it.
Vermont at this point. as well.
Correct.
Okay, that's helpful.
We're smaller than for people who are actually willing to do that.
No, that's
the
great.
pe-
Yeah,
Yeah,
because if they're not willing, it doesn't work.
right, it doesn't.
Right. Okay, thank you. That was important.
I'm gonna go to Isaac first and then Mary.
Yeah, no, I just remind the committee that, we're part of the Agency of Human Services, so we're one of 6 departments. We're really fortunate to be the only correctional system in the country that's part of the Human Services Agency. Joined here with my colleague from GMH, but would invite the committee, either this end of this session or next to continue exploring this topic. I mean, I think thinking about community resources and placements and facilities is really beyond our jurisdiction. Obviously, we want to be a part of those conversations, but just thinking about deferring a bit to our partners at GMH and really talking to the Secretary of AHS to think about what that holistic system of care looks like across the state.
Mary?
Had a question. You had indicated, Allison, Dr. Richards, that you were uncomfortable if people were not leaving with their 30-day or 28-day prescription when they leave the facility. And we had a week or two ago someone that came in that deals directly with patients that said one of her fears or concerns was the fact that some of our incarcerated are leaving with that amount of medication, understanding many different things could happen with it. So I'm a little conflicted as to what is good, appropriate, and what's not.
Right, so we provide 30 days to sentenced individuals at this time. I'm okay with that. I mean, I think there seems to be some flexibility if what you're saying is, if you're giving somebody like gentleman I mentioned on 9 medications, 30-day supply of 9 different medications, that's a lot of pills, and what could be done with those. Each person is individual. And so I think the way I've instructed my providers to approach it is like, if you have concerns about somebody potentially overdosing or being a risk and giving them those medications, then our goal would be to coordinate with their provider in the community and get them an appointment, like within a week. That would be the standard practice in psychiatry, to get a soon appointment and give somebody like 7 days of medications and get them to their appointment so that they don't have that. Is that kind of what you were?
Right, and does that happen more often than not, like a 7-day type of thing?
Well, I don't have any data on that, but I could check in with data. I can check in with my providers though to see how that's going. I think if we were that concerned, I would probably have heard about it. So I'm assuming it hasn't
Right.
happened.
This nurse really said that
Mhm.
is one of her greatest fears.
What was she? Do you know what she was?
I think she was afraid, again, depending upon how many medications, but also possibly someone leaving with that and selling it and getting kind of right back on the
Yeah.
not a good path, shall we say. And so she really impacted me when she said that was one of her greatest concerns.
Yeah, I mean, it definitely was a concern of ours, and I think every patient's unique, and it's always a risk,
Right, yeah, I
that when
know.
you're giving somebody a prescription that they could do other things with it. So I think that, not to get back too much, to, addiction and co-occurring treatment of mental health and substance use, and the amphetamine use that we see sort of rising in Vermont and the prescriptions for stimulants, I would encourage you to find that article and read it, because the researchers that first were really promoting amphetamines for children, for ADHD, the research and the studies, the initial data looked really good. And then when you followed them out further, it was like, oh, it's not really what it may seem. And some of the original researchers are kind of like, we need to rethink how we're treating individuals with stimulants. And again, some people need it, some people may. There are other treatments, but the focus of the article was sort of like the environment. And as a child psychiatrist, in our school settings, that's beyond the scope of this meeting, but just the way that we're kind of just, here you got ADHD, the rates are up like 24% of 17-year-old males have ADHD currently in the United States, and it used to be a 3% prevalence. So some of that, I think the statute does sort of force our hand, like we have to. And you may have somebody in the community that's threatening a provider, and I don't want to put the provider in the community in the middle of that dilemma once somebody's released potentially. So coordinating care can also be challenging, because I don't want to call and say, do you still want to prescribe this to somebody? They might be like, keep me out of it, So it's a complicated system.
Yeah, or the incarcerated individual doesn't want us calling the community
Well, they won't,
prescriber
yes.
because we now know information about their substance use that their community provider may not know. And so the community provider may change their minds if they actually knew all what was going on.
Very
But in
tricky.
the absence,
I have
in the
to
absence of that information though,
They wouldn't know.
then you're literally putting the person at risk, because a doctor who in good intent wants to help is working with ignorance.
Mhm.
So that law doesn't make sense to me that they.
Are you talking about
share
HIPAA?
professional-
You're talking about HIPAA?
Yeah.
Yeah, with the 42 CFR and substance use. I mean, we can coordinate care in an emergency, but my approach has been, if it's not an emergency and somebody's on a medication, I prefer to say, would you sign a release for me to talk to your provider? And they're like, no, I don't want you to talk to them. And it's like, well, then then we may not prescribe this medication while you're incarcerated, but then people are in and out and they go back and they're like, it's okay, I'll just get it when I leave and go to the community. It's an interesting phenomena. I've only been with WellPath and Correction since January of 2024, so it's a new experience for me.
Well, I have to say, I can't thank you both enough for what you do. It's very obvious that you're passionate about the care you provide, so thank you.
Thanks, thank you.
Connor, and then we're gonna have to wrap it up because we've got to shift gears to talk about River Valley and those beds.
No, just kind of a wrap up comment piggybacking off Isaac there. I'd really like to spend some time next session working at this. There's that expression like we never deinstitutionalize people.
No, we are.
We only move them to another institution.
Correct.
And when you look at 56% on the mental health caseload, that's what it is right there. And like we're spending top dollar right now. If somebody's 10 years past their minimum and we can't find a place for them, that's very expensive. So take the compassion out of it even. Can we spend this money in a more intelligent fashion that actually helps people? So I think we have a lot of work just as far as the future of our system, the physical buildings around it. Are we going in the right direction? So, yeah.
You can't do it for one gender versus another gender. You gotta do it. I hate to wrap this up, but we have BGS that's waiting. If you could send them an email, send Wanda an email. They're in the cafeteria.
Oh, okay. The New York Times
Oh, speak of
article.
Wanda, come on in. We're just finishing.
We can send it around. I can start.
Nice.
I just want to see if you can tell me, and then I'll print it out.
Oh, if it's the right. Yeah, okay. Yeah, thank you. Thank you, guys.
So we're,
Yeah. It's like, are we?
you need to take a
Now
quick
we
break,
need- we
take a
can't see
quick
both.
break.
Way ahead of the game.
Still on YouTube, folks.
Guys, on YouTube.
On YouTube, folks, hang on. Okay, no.
Thank you.
Oh, sorry.
So Karen is on
Yeah,
Zoom. No, Karen is still on Zoom. Good. Hi, Karen. So we're gonna shift gears here quickly. We're gonna have some conversation with Department of Mental Health as well as maybe BGS, and we do have a member of the House Healthcare Committee. Daisy, I have such a hard time with your last name. Rebecca. Who was on the is on the Healthcare Committee. Jason, do you need us? It's Jason Malucci. Troy? Jason Malucci was just poking in. Is that for
Sean's on it. It's, is that 219?
Jason Malucci was just out there. Did you get some? Okay.
That's it.
That is.
So we're going on with this?
Yeah, Karen, we're looking at River Valley and the use of those beds. And we're just trying to clarify whether they're just for mental health folks, for the EIPs, or if those EIPs are also going to be used for forensic folks. Because I think there's some misunderstanding or not clarity in language.
Yeah.
I'll be right back.
Yeah. So take it away, Karen. Well, introduce yourself for the record and then.
Thank you. My name is Karen Barber. I'm General Counsel of the Department of Mental Health, or DMH. So I was actually going to back up a tiny bit because I think I listened to the testimony last week. It sounds like there was a little bit of confusion. So for the past couple of years, we have been talking about forensics, right? And building a forensic facility. The idea was that it would be a joint DMH scale facility. We had kind of contemplated what it could look like, where it could be. At the end of last year, so the version of S192 that started off last year looked very different by the time it passed, right, and became Act 137. And it became clear to us, I think around the beginning of February, that there was not enough support for a forensic facility. And so at that point, DMH really started thinking about what do we think would be most beneficial to our system of care? Where are there gaps? Where could we improve the care that we give our folks? And so that's really where Act 137 ended up going. We had identified 3 changes we thought we could make to River Valley that would help us serve those folks there. So it wasn't a forensic facility. It was separate from the forensic conversation. We had really kind of put a pause to that because there wasn't legislative buy-in for that. And we really switched to just thinking about what the DMH system could use. So there were 3 things for River Valley specifically that came out of Act 137. And just to kind of back up a little bit, just to say, who is that River Valley? So River Valley is the only physically secure residential facility in Vermont. So there are staff secure facilities, meaning they're staffed 24/7, but we are the only one that has locked doors. Everyone there is involuntarily in the custody of the Commissioner of Mental Health on what's known as an ONH, or an order of non-hospitalization. And to go to River Valley, it's a special ONH. So there are lots of people in the community on orders of non-hospitalization. It's a special one that you need for River Valley because the court has to specifically find that there's no less restrictive setting that would be appropriate. And in order to be eligible for River Valley, you must need intensive residential mental health services in a secure setting. So basically, you don't need a hospital level of care, but your mental health needs remain acute enough that you need 24/7 care. So those are the kind of population we're talking about. Just with all individuals under our care and custody, we determine their placement solely based on their clinical needs, not where they came from. So like our hospitals, we do serve individuals that initially came into our system through different doors. Some come in through the civil door, some come in through the criminal door. We don't differentiate treatment or placement for those folks based on what door they came through. It's really based on their needs. So River Valley, that's kind of the population of people we serve. So we had asked last session to make 3 changes to River Valley. 2 of them are not new. 2 of them are things that we had initially asked the legislature for when we came to them with the plans for River Valley, because River Valley replaced the Middlesex facility. And those 2 things were EIP and involuntary medication. So first I'll talk about EIPs. And where you see that in Act 137 is in section 17, and that's where it gives Dale the ability to change its rules for licensure, because the reason we couldn't do EIPs or involuntary medications was based on our license, which is through Dale as a therapeutic community residence. So what is an EIP? It's a seclusion or restraint, also called emergency involuntary procedures. It also includes emergency medications. So those are different than long-acting court. So there's court-ordered involuntary medications, which are kind of long-acting treatment medications. And then there's emergency medications, which you can give in an emergency. And so those are allowed as part of an EIP. Those are different things. And so why did we always think we could have used the tool of EIPs at River Valley? So there are some folks certainly that if you're having a lot of EIPs, if you're really needing a lot of seclusion or restraint, then clearly you're not appropriate for residential, right? You're really probably needing hospital level care and needing to be in a hospital. But there are some folks that can and should be served in a residential level of care, but do have a need for what we call episodic EIPs. So they don't happen often, but sometimes they happen. And before, because we couldn't do EIPs at River Valley or Middlesex, it meant we had to remove them from the facility and we had to send them to a hospital, which in most cases was not good clinical care, right? Because they didn't need a higher level of care. They didn't need to go back to a hospital. What they really needed was to be able to have that temporary seclusion or restraint, and then to be able to work through what happened with their treatment team and continue to work towards discharge. And we always really wanted to have that ability to provide good clinical care at River Valley. The decision initially was made to not allow us to do that, but last year when we revisited it, they did give us the ability to do that in statute. Statute directing us to change rules. So now that rule has been changed, we can do that. And it helps the system as a whole, right? Because we have folks in the hospital that can and should be discharged, other than they do have this kind of need for episodic EIPs, and that makes it really hard for a community-based setting to accept them. So this gives them another form of step down where they can get the appropriate treatment they need and continue on their path to returning back into the community. I also wanted to clarify, because there seemed to be some confusion about people coming in through the criminal door being more dangerous. When you look at our system of care and you look at our EIP numbers across the system, by far the most number of EIPs are on folks that are coming in through the civil door. It is not an indicator or a predictor if someone comes in through the criminal system. And again, oftentimes those are not the folks that are getting EIPs or even having high number of EIPs. So just kind of wanted to clarify that. The second change that was made in Act 137 was court-ordered involuntary medications. Again, those were something we had asked for initially and didn't get, but we did get last year. That is also found in section 17, because that's, again, the place where it's directing Dale to change the rule. And so basically this is court-ordered medications, right? So right now, you know, if someone's in the hospital and they're not taking medications, we can apply to the court to say we think that they really need medications, and then the court can make a determination. Our license didn't allow us to administer those medications at River Valley, and we really saw that as a gap in care, because we would have folks that, you know, once you're stabilized on medications, we have an acute care hospital system. You can't just keep someone in the hospital because you are guessing that they are going to go off their meds as soon as they go into the community. But oftentimes that happens, right? And then they cycle through. And so this allows us, again, another step down step where they can receive quality clinical care in a secure setting and also get the involuntary medications they need so that they continue on their treatment path. And then hopefully they agree to take medication voluntarily when they get out in the community, but it gives them a longer runway and more of a time to receive that treatment. The third change is a new change. Originally, when Middlesex was created and then River Valley, it was really thought to be a step down from an inpatient unit. Not just BPCH, I want to make it clear that anyone from any inpatient setting could go to River Valley. Again, it's not about where you started, right? It's about your clinical need and who has that need. Often it is more the level 1 facilities, which are River Valley, which are BPCH, Rutland, and Brattleboro. They all have units that tend to have folks that might need this level of setting, but it's not limited to them. But what we have been seeing throughout the years of operating this facility was that there were folks that didn't meet hospital level of care, but that still needed a secure setting for their needs. And so by the statute not allowing them to go into River Valley, we were really not able to serve some folks that really could benefit from that level of care. So the third change we asked was that statute be changed, and that can be seen in sections 10 through 13 of the Act, where now, depending on at what point in the process, but now we can ask legally for them to come directly from the community and be admitted into River Valley. So those are the three big things that came out of Act 137 that made changes to River Valley. The presentation you had from BGS about building a seclusion and restraint room is because that was originally in the blueprints when we asked to do it at River Valley initially, but because the legislature at that time made the decision not to allow us to do it, we repurposed those rooms. So now we need to build a seclusion and restraint suite is what we call it. And so that is what we're trying to do there.
So first of all, thank you for some of this information. And I know that a few of us have been around a little bit. We had memories of conversations about there being 8 forensic beds, which was a confusion. And that's in multiple different committees. So how the bill actually left, I guess maybe there's some confusion, maybe it's not, but you're saying that there's not really 8 assigned forensic beds, or am I misunderstanding?
No, you're correct. There are no forensic beds anywhere in the system. We do treat folks, again, that come in through the criminal door or they come in through the civil door, but we do not have any beds throughout our system that are designed specifically for folks that come in through the criminal door. And we had talked about various numbers. We had never actually talked about River Valley being a place where we could house a forensic facility. What we had initially talked about was potentially BPCH, because of the way BPCH is designed. There's 2 8-bed units, and then there's a 5-bed and a 4-bed unit. And so we talked about using the 5 and 4-bed units, so 9 beds actually. But what became really clear to us is CMS would not allow that, and we would lose our funding. So then we pivoted and said, well, it can't be VPCH. We'll have to think about where it could be. And that's when conversations really there was a lot of disagreement too about whether Dale would be involved in this population and whatnot. But that was kind of the initial proposal, and then it morphed, and then eventually we switched to not focusing on forensics, but really just thinking about the DMH system as a whole.
Is this interesting? But DMH has not had those conversations, I guess, but like in the building, in certain committees, human services, healthcare, and here, we certainly had conversations about forensic. But where that went, I mean, things left, and we don't always have the best memories, but I'm not the only one that recalls having conversations, including chairs of other committees, about having conversations about 8 forensic beds. But Troy has a question, and then Mary.
What is the current conversation about the desire for, from the administration, the desire for a forensic facility or forensic beds?
Yeah. And so just to clarify, yes, there was lots of talk about beds. Like we testified for 2 years on forensic beds. What I'm saying is that switched in April of last year, and then we pivoted, but absolutely, I testified for 2 years on it. The administration, we did not put forward a proposal for a forensic facility this year.
But what is in a general sense, what is the futures conversation about that? Like, where do you see that in a 5-year plan, a 10-year plan?
Yeah, I think it's really too early to say, right? So I focused really this presentation today on the DMH portion. So we felt that there were a lot of people we could better serve, both on the civil and on the criminal side, by making these changes to River Valley. Dale also was working on creating some beds for their folks. They don't have any residential type facilities in the Dale system. And so I think that is something they're still proceeding with. So, which are kind of the two different things that came out of this legislation. So I think it's too early to say what the needs might be because we haven't really gotten up and running with the changes that were implemented last session.
And just one clarifying question, it is accurate to state that once these renovations are complete, a person needing forensic bed could end up in this wing. Does that feel accurate?
So I just want to be really careful about the word forensic.
I know.
I think people define it different ways, right?
Yeah.
So some people say it's if they're waiting for a competency eval or they've been found not competent. And some people are saying it's anytime they come from corrections.
Right.
So again, we don't look at people from where they come from. Yes,
Gotcha.
Currently now we have folks that came in through the criminal door. We will continue to serve folks that come in through the criminal door if they meet this level of care. And I just want to be really clear, right? They don't come in because they had involvement with the criminal court. They come in because they have that level of need. That's a really important thing in terms of Medicaid funding, right? They're there because there's a clinical need. We do use Medicaid to pay for River Valley. But yes, we serve folks now and we will continue to serve folks. This tool will allow us to serve more folks no matter what door they come in. It could be the criminal door, it could be the civil door.
I appreciate the clarification and I understand. Thank you.
Mary?
I heard you say two different things. You originally said that the legislature kind of changed their tone on having a forensic. And then later in what you told us, you talked about 3 agencies kind of changing their thoughts on it. So which is it? Who changed their mind in midstream about this? Because just as Representative Gregar had said, there were 3 committees that talked intensely about this. You know, I think about my own senator, the late Senator Dick Sears, who was very passionate about this. And we were getting to that point of possibly implementing some beds. And now all of a sudden, it may take 5, 10, whatever years. We are 1 or 2 states in the country that do not have a forensic facility. And I think we've seen some of the activities going on in our state that would probably recommend we have something for folks as they're being evaluated or not that are of significant need for that. But if you could have, first of all, explain, it was the legislature over the 3 departments you discussed that changed your direction on it. I would appreciate the answer.
Sure. Yeah, I think it's a little more nuanced than that. So I don't know that anyone. So I think we spent a couple years testifying on a potential facility, and there was a lot of disagreement in different committees about whether or not they supported the idea or not, right? And there was a lot of pushback from advocacy groups as well about whether or not it was a good idea. So it was always kind of in flux, right? It was always being debated, and we kind of pivoted and moved. And when it became kind of clear to us that there just simply wasn't likely going to be enough support for the facility as we originally envisioned it, what we did as an agency was say, what could we do to benefit our departments, to benefit the folks that we serve, right? Because our goal is always to provide quality clinical care in the least restrictive setting. And then Dale also has their mandate. So DMH went back and thought about what we could do to help better serve our folks. And that does help with, when you say forensics, it's hard to know exactly who we're talking about, right? But it does help folks that come in through the criminal door. And then on the Dale side, they are also working to make changes to their system that also would positively impact folks that I think you're labeling forensic. So while the facility itself did not get created and there is no brick and mortar building, we did get a lot of great tools last session that is allowing both DMH and Dale to better help provide services to the people we serve, including the folks that are coming in through the criminal justice system. So I don't think that it turned out that we got nothing. I think what it means is it looks a little different than we originally envisioned it, but we both got tools that are helping us deal with those populations.
Brian?
Brett Morrissey just about aced me out, but I think it's just different enough. I don't know if you're comfortable sort of coloring, characterizing the disagreement, the pushback from the various groups. You know, was this a cost thing? Was this we don't see the point? Was this NIMBYism? Was this don't build any more beds? Was all of the above? What was the pushback?
Well, I think it's hard to, I think there were different reasons people were concerned. One, I think we're a state that really values serving people in the least restrictive setting possible, right? Our goal is always to get people out as soon as possible into the community. People do not stay in the hospitals like they used to. They don't stay in River Valley, you know, for longer than they need. And so there's always a goal to get people out in the community. And so there's always a concern by certain folks about building more beds, right? If you build more beds, they will come. Do we really want to build institutions, or do we want to focus on serving people in the community, right? That's just a basic philosophical divide about how we look at folks.
Yep.
I think there was, sorry.
No, I'm just agreeing, yes.
I think there's a concern about criminalizing mental illness, right? So right now, all these folks are served together, right? They are served based on their clinical need. We don't divide them up. We don't treat them differently based on where they come from. And so there was a desire not to do that, right? Not to have them separate. We are different, right? I think we are probably one of the only states, if not the only state, without some sort of a forensic system of care. They look different in every state. We don't have a general fund hospital, right? And so we only have Medicaid funded hospitals, CMS certified Joint Commission accredited hospitals, including our state hospital, which means you have to meet pretty strict clinical criteria to be admitted to the hospital, and you have to be discharged as soon as you no longer meet that level of care. That is different than, say, a general fund state hospital. It's different than what the Vermont State Hospital used to be like, right? So we just have a very different system of care. So it's also hard to compare us to other states. One of the things we also spent a lot of time testifying about was competency restoration, right? So we don't have a competency restoration program. And so the other thing is, we talked about, okay, maybe we'll build this facility where we can house these folks, but part of kind of our desire initially was to have a competency restoration program that would help potentially restore them to competency so they weren't getting stuck in the system. That was another big conversation.
You said it so fast I didn't understand what you were saying.
Go ahead. Sean has a question.
Karen, just can you go back, or what did you call that just then?
Which one? Competency restoration?
Competency and restoration. What?
Yeah.
All right, I got it.
She's going to tell you.
Sure. So competency restoration, I do think we are the only state without some form of competency restoration. It's basically, so right now, right, if you are charged with a crime and there's a concern that you're not competent, that's a legal term, not a clinical term, which basically means you need to understand the charges against you, you need to understand how the court system works, and you need to be able to work with your attorney, essentially. Yeah. If you're found not competent, you can't go to trial, right? It's part of your constitutional rights. Most other states, almost every other state, will then have a program that will attempt to restore people to competency so that they can go on and go to trial for their crimes. And in Vermont, we don't have that. And so when we talk about a forensic system, it's not just about beds for folks. It's also about what kind of treatment offerings are you going to have in those beds? And so when we initially were talking about this, we had talked about it in terms of having a facility that could also do competency restoration. And we talked about competency restoration for mental health and also for those with intellectual disabilities. Those programs look different. We submitted a report, I think last year, about best practices and competency restoration. And so those two things are really, in our mind, tied together. But also competency restoration in and of itself is fairly controversial.
Karen, I might just deviate a little bit, but I want to piggyback, I think you said it well, there's a bit of tension in Vermont between wanting to treat people in the least restrictive setting as possible while making sure them and those around them are safe, right? And like, this has always been going on in Vermont, but, I was up at the psychiatric hospital just meeting with workers a few weeks ago, like 10 or 15 of them. And I felt like, morale was pretty bad, and it was bad because they were afraid, and they were afraid that, they had seen a traveling nurse go into critical care recently as a result of injuries. And I think, if you look at it, at least traditionally workers' comp rates and DMH are sometimes higher than even corrections, right? It's a very challenging job there. So I just wonder if you could just help me give me some peace of mind, whether the department, and maybe you're not the right person to answer this question, what are we doing to make them feel safer? Do we feel like the current laws on the books are appropriate? I don't really have an opinion one way or the other on that one. But I just want to make sure people who are working these tough jobs feel like they can do it safely, So didn't know if you had a comment on that.
Sure. Yeah. So folks with folks with acute mental illness sometimes can become violent, right? That is unfortunately just part of the job. We require that all of our hospitals have their staff trained in some sort of de-escalation techniques so that they know how to try to engage and talk with the person, and then also how to do EIPs safely. So if we're talking about VPCH specifically, we use PROACT. We do have some of the lowest number of EIPs in the country in all of Vermont, and VPCH itself has some of the lowest in the state. So I know it feels like there are a lot of them, but if you look at countrywide, we are actually very low. We are very good at working on de-escalation. I think one of the nice things about our hospitals is they're often designed in a way that gives people space. So especially at VPCH, we have 2 yards. If someone needs to go outside, we can send them outside. And so we do work very, very hard to de-escalate. Sometimes, yes, it is necessary. I think also it goes in waves, right? And then sometimes you have the hospital, frankly, at VPCH has been very acute lately. And our numbers are higher lately than they normally are. We've had a couple patients that did have a lot of EIPs, and we really worked as a team to try to help support VPCH. The commissioner and myself actually spent a week at the hospital just meeting with staff, talking about different ways we could help support them. We do have, in Vermont, we have an emergency and voluntary procedure administrative rule. And that rule is stricter than what CMS and Joint Commission require. And that was a decision that was made. I think it's still fairly in line with most other states, but there are regulations around when you can seclude and restrain someone, and how you can do it in a safe manner. DMH Quality gets all of the reports of EIPs, and we review every single one of them. And if we have any concerns about what happened or things that could be done differently, the quality team reaches out. So what I can say is that there is a lot of oversight and a lot of support, a lot of training opportunities. It is unfortunately part of the job that is probably never going to go away, right? Is that sometimes people will act in ways that put themselves or others in danger, and we will need to intervene and seclude and restrain or do emergency medications. But we try to make sure that staff are the best prepared they can be to do so in a safe way.
And do you feel like those meetings that you and the commissioner had with staff was a good back and forth that resulted maybe in some tangible steps, to make them feel better about going to work every morning where they don't feel in danger,
I hope so. Yeah. So VPCH is our hospital. So it's easiest for me to talk about my hospital rather than other hospitals, but they do have a safety committee that they've had for several years where staff do meet with leadership on a regular basis to talk through different ideas they have or safety concerns. I also know that based on a couple of really acute patients recently, we did have some, the CEO did have some full staff meetings to kind of just get simply get staff feedback. What could we have done differently? What do you think we could do better? What do you think we could change? And so they are working on those things. So we do try really hard to make sure staff are heard. Staff don't always feel heard, right? But we try as hard as we can, and we're always open to different ways to hear that from them. But I do think that we were received well. And I hope that they got the sense that we were there and really supporting them.
And before I go to Mary, Daisy, do you have any questions or comments from healthcare, or you just? No, okay, Mary.
So, well, can I just
Yeah.
interrupt? Have we figured out the use of those beds at River Valley?
They
Okay.
insist that there's no forensic beds, so.
Okay, Mary?
No, I'm not going to ask.
Well, we can use the beds according to clinical need, whether or not those people are arriving through the civil process or the criminal process.
Sorry, Troy.
We can use those beds for determining, according to the clinical needs of the individual, whether or not that individual is arriving through the civil process or through a criminal process. That's how it's been phrased to us.
So a criminal process, that would be forensic, correct?
I believe that's only true if the facility is exclusively forensic beds, excuse me, for criminal origins. Is that what you said earlier, or am I misrepresenting?
Yeah, so it's hard. People use the word forensic. In our world, we don't differentiate people by where they come from. And also when you're talking forensic, some people are saying it's folks that they're waiting for an evaluation for competency, or folks that have been found incompetent or insane, or they're folks that are coming from already been sentenced and they decompensate in prison and they end up coming into our system to get mental health treatment and go back, right? So there's lots of different ways you can think about forensics. I guess we look at it broadly in terms of, are you talking about people coming in through the criminal door or the civil door? But those are folks that we have always served and we can always serve as long as they meet the clinical thresholds. We just don't have beds just for them.
So is the new model for the 3 agencies you've discussed similar to what you did in my community, where you put 3 different populations into what was originally a nursing home, and using your terms, these were folks that could not be placed anywhere in the state, and you put them in a population of a nursing home with folks coming from prison with significant issues, mental health issues, as well as opioid issues. The community did not, and there was a big turnout for the hearing we had, and none of the agencies listened. So is this going to be the model going forward, to put folks of different challenging needs into nursing homes where you think they can get this community care of whatever? And the conversations were very difficult throughout it as to what you folks actually meant by what was going to happen in them. So is that the model that's going to go across the state?
Sure. So DMH does not run nursing homes, so I can't speak to.
Well, jail was very involved in this what happened.
Yeah, so I'm
So
not.
they are part of the 3 you're talking about.
We're all under the umbrella of the Agency of Human Services. What I can say, backing up a little bit, is one, there is no new model, right? River Valley hasn't changed. We've always served all individuals who need to be in our facility. Do some people have co-occurring substance use disorders? Sure. Do some have co-occurring intellectual developmental disabilities? Sure. Do some have all 3? Absolutely. Right. That's just how you kind of see the population. What we're treating, though, is we don't tease people out based on their what also they may have going on. Again, we look at the clinical presentation. Do they need the clinical care that we can provide? And are we the most appropriate place for them? If the answer is yes, then we serve them. It doesn't matter where they've come from. It doesn't matter what they struggle with, right? We're really concerned with looking at the person as a whole and treating them holistically and giving them the treatment they need. So that's the same for across the agency, right? Like, we do want to break down silos. We want to serve people in a holistic way. We want to make sure all of their needs are met. And what we see is it's really hard to say, well, 50% of, or 51% of your problem is mental health and 49% is substance use. So we're gonna, you know what I mean? It's really hard to tease that out and say where you're going to place them. So we really just focus on what do they need, what can we provide, and where's the best, least restrictive setting we can provide them those services. And that's not a new model.
Thank you.
So where are we? I'm sorry I missed this. Something popped up that had to be taken care of.
I think the thing that it has nothing to do with what Ms. Barbara can tell us, but we as a legislative people, we have to try to figure out the whole thing about forensics, right? Because a lot of us remember having talks about having the forensics vets. The DMH says no, but that's not thing we're going to solve here. But we got to look into the history and try to figure that out. But we had great testimony on what the use is and the EIPs, et cetera.
So who's going to be housed at the renovations that's occurring at the facility? People are aware of the renovations that are occurring at River Valley in order to allow EIPs. Who is DMH going to house there? And do you need a separate entrance?
So the same people we always have served, right? So folks that are involuntarily under our care and custody on a special type of ONH, order of non-hospitalization, which finds that there's no less restrictive setting for them to be served in. So it's folks that don't meet hospital level of care, but continue to have acute mental health needs that require 24-hour treatment in a secure setting. So the same folks we serve now will continue to be served there. What these things do are give us more tools to make sure, one, we can better serve folks and that we can take more individuals that maybe we couldn't before because their clinical needs were a bit too acute for us to handle. So it doesn't change who we serve.
Do they need to be physically separated from the other 8 beds? Do they need a separate entrance?
Nope. Again, because it's all the same people, right? There's no forensics versus non-forensics. It's simply people in our care and custody getting mental health treatment. So we're not treating them differently, right? So one of the things I talked about a lot before you came on is people come to us through the criminal door and people come to us through the civil door. We don't treat them differently and we don't tease them out. And they come to us purely for mental health treatment. If, like we were talking about before, when we did have a lot of testimony and discussion on a forensic facility, Medicaid is really clear that they won't pay for folks just sent by the criminal court just to kind of be held somewhere, right? And so that's when we were talking about at VPCH, when we initially had kind of talked about putting a unit at VPCH, they needed to be completely separated from the rest of VPCH. And then we realized that even that wasn't enough and it just wasn't possible, that we would just lose our Medicaid funding. We're not talking about that with River Valley. We're simply talking about the same population we've always been talking about, just simply giving us some more tools. So EIPs are used, frankly, more on civil folks often. We see higher number of EIPs on folks that are coming in through the civil system, through the criminal system. They're used in all the hospitals today. It's just a tool. It's a clinical tool to use when someone has become dysregulated to the point where they're a danger to self or others. But it has nothing to do with whether or not they're forensic or they've come in through the criminal system.
So I'm going to ask Daisy, and I'll put you on the hot seat. Maybe you've already been asked this. Was that the intent of the legislation last year that went through your committee that focused in on these beds at River Valley to convert them in use? That it would be just for folks coming from the state hospital and would not be for forensic beds?
Which piece of legislation are you referring to?
It was,
192.
what was the bill number?
192.
192, yeah.
Act 136.
Because that's where the language in the capital bill for 50,000 to do renovations at the building to comply with EIPs came from, because it was our understanding last year that the EIPs were needed in order to hold forensic folks. So
Yeah,
that was the
my
intent.
understanding as well.
That was your understanding as well in the committee, being that forensic folks would be housed here?
That they could be, and that's why we needed to support the EIP at the facility, yes.
So what DMH is saying, that you're not seeing those folks that would be housed in these 8 beds as forensic folks, because you're currently taking care of them at the current state psychiatric hospital.
Well, Madam Chair, I am hearing, Karen is consistent with what she has said all along, and that is that what happens in the facility is based on clinical decision-making. And that's that regardless of where people are coming in from, they're going to do what's clinically appropriate. And her testimony here is consistent with what we've always heard from her.
So how does that, and I understand what Karen is saying, how does that translate into what the intent was, that there'd be some forensic folks housed at River Valley?
Well, similarly, in our committee, you know, with jurisdiction over mental health, we support that this facility be treating people with mental health needs. And if the acuity is such that they need emergency and voluntary procedures, we agreed as a committee to support that. And if folks who are in the care of corrections have a need that is primarily for mental health care, they should be in the care of the Department of Mental Health.
That's a little difficult.
Very different from what we.
Complicated.
I think you're getting hung up on the word forensic, frankly, because we do serve, I think, people you would consider forensic. We just don't call them that, and we don't treat them differently because of that, but we do treat them there, right? They're already there. This gives us more tools to serve maybe more of them, also more civil folks, right? So it's a tool that helps everyone, but it certainly doesn't mean we don't serve them. We do, we always have. Right, there's not a bed that says this bed is only for people who are coming out of corrections. Really, we just have beds, and if people need the beds, then we work to get them into the beds regardless of where they come from. But we are serving, I think, the population you're getting at, if they need that level of care.
But to clarify, you're not doing competency restoration.
No, nowhere in the state do we do competency restoration.
You're at the psychiatric hospital.
That's a.
Nowhere.
Nowhere in the state.
There's nowhere. Will.
Just real quick, Karen, because I'm kind of lost on this with population, and you're saying that we're not treating them differently. And I don't mean this to come off, insincere, but what if we do need to be treating them differently in terms of the care that we're giving them and the different levels that they're at? And I think that's kind of, you're saying that there's forensic and there's not forensic, and that we're just not using that word. But how are you going about classifying the different parts of the population that you're serving? I have to be honest, I'm very lost.
Sure. So we look at individuals' clinical needs, right? So that's why we have people in the community on orders of non-hospitalization. We have people at River Valley on orders of non-hospitalization, the special type we talked about. And then we have folks spread out across 7 inpatient facilities across the state, right? Some of those units are designed to treat individuals with more acute needs than others. Sometimes those are called level 1 beds. And really, that's a contract term. All it really means is that those have higher staffing patterns, right? So there are different facilities that manage different levels. And so like any other, medical issue, there are, the acuity of your symptoms at the moment is what kind of determines where you need to be. Someone's mental health needs don't change whether or not they're coming in from an ED or they're coming in through corrections, right? Like mental health treatment is mental health treatment. I think what you're getting at maybe is once they're treated for their mental illness, it doesn't necessarily mean that if there was a criminogenic component to their behavior, that's fixed simply because they got mental health treatment, right? And so there is a public safety component. And I think that's a different conversation because what we're really looking at is their clinical needs and we're treating their clinical needs. But from that perspective, the treatment needs aren't different for individuals. Every treatment is individualized, right? So every person needs something a little different. That's why they have treatment teams. that meet often and create individualized plans to help folks, and those change as the person is going through their journey, and we're always constantly updating those treatment plans to meet them where they're at. But treatment is really individualized. It doesn't matter where you come from. It's really about what do you as a person need.
Okay, I'm gonna try my best to look over this and follow up with you because I'm just having a lot of difficulty putting these pieces together, but thank you for that information.
Sure, I'm always happy to chat. The mental health system is complex and it's can be confusing. So I'm always happy to take time to explain it to people.
So basically, by allowing EIPs to be used at River Valley and doing the renovations in the building to accommodate EIP implementation, it would be for only 8 beds in the facility. Well, that's what we've been hearing, 8 beds. You're shaking your head now and saying it's.
For anyone in the facility.
Is it anyone in the facility? We were hearing testimony was for an 8-bed wing.
So I think there was some confusion. I did listen to the testimony. I think, unfortunately, Sabrina she is great at what she does, but I don't think she understands the mental health component of it. And so I don't know that she was necessarily saying just those 8 beds. I think it's on one of the wings, right? So it's at the end of one of the wings, and we met as a leadership to talk about where would be the best place to kind of put this emergency and volunteer procedure suite. So it is on one of the wings, but it had to be somewhere, right? But it's not limited to those wings, and certainly it won't be cut off, right? The facility is open. It's just that's where it happens to be.
So we're going back to what the facility was originally designed to be, was to carry out EIPs in the whole facility for 16 beds, regardless of how someone gets there.
Correct. Yep.
So we're going back to the original part that we had decided 4 years ago. And then the following year, the EIP piece got pulled. So this is just putting it back in the facility.
Yes. Yep.
For the whole thing. And last year, the conversation was having those beds for forensic. And in order, if you have those beds for forensic, you need to have the EIPs there. That was the conversation last year at the end of the session. So now the whole focus has come into focus. So it's the whole building, it's the 16 beds. EIPs will be used for the whole River Valley Therapeutic Center.
For anyone,
for anyone
who needs them. Yeah, I don't think DMH was never offering up River Valley as a forensic facility. I think what we consistently said, though, is that we serve people that come in through the criminal door, and we will continue to serve them, and this will give us tools to help them.
But I think it was the legislative committees that were talking about using a few beds at River Valley for forensic use.
Yeah, which would have had Medicaid implications, right? So when you start, that's why we're really careful.
That's why you needed that separation of separate entrance, separate treatment room, separate living room. We went through that when we were looking for the forensic unit down at the psychiatric hospital.
Correct.
And we pushed, and we, in this committee, there was Troy and Mary and Connor, we pushed back on you folks on that because we were saying then that we'd lose our Medicaid, and DMH was saying, no, we wouldn't. And then when you started looking at it, you found out, yes, you would lose Medicaid. So we pushed back on the state hospital.
And so then they flipped again.
So anyway, there's a lot of history on this that you folks are catching up on.
Been very informative.
So basically what we're left with now is River Valley, the full 16 beds. EIPs will be implemented for all 16 beds. And what renovations are occurring is isolation room, restraints, and they can use physical restraints and medication for those 16 beds.
Correct.
Is that correct?
Any resident who needs, so there's a rule and there's regulations around when those things can be used. But if they are adequate, if they clinically need those things, or there's a court order in terms of court ordered medications, then yes, they now can be implemented there. The rules, the TCR regulations have been amended to allow for those things pursuant to the statutory language. And staff are currently being trained. We haven't rolled it out yet. We expect July 1, but staff are being trained.
Anything else on this for the
Man.
committee?
Thank you so much.
Thanks, Karen.
Thank you, Karen.
You've been
Yeah.
there.
We gotta wrap it up. Thank you, Daisy, for coming in. We appreciate it. Thank you. I hope we're as clear as mud on this.
Absolutely.
So let's go off of YouTube. We're on the floor at
Thank
1
you.
o'clock.